Hello, welcome to the CIN webinar, Value-Based Payment Readiness Assessment, One Consortia's Experience in Southern California. This webinar features CIN partner, Health Center Partners of Southern California, and the managed Medi-Cal Value-Based Payment Readiness Assessment they did with 9 of their member health centers. My name is Marie Hubbard, and I'm the Program Manager for the California Improvement Network, or CIN. For those of you that aren't familiar with CIN, CIN is a network of quality improvement leaders focused on innovation in healthcare. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. A few logistics before we get started. Everyone is on mute except for our presenter. If you would like to ask a question, please use the Q&A function or the chat box located on the bottom panel of your screen. We'll try to get to as many questions as we can within the hour. This webinar will be recorded. Both the PowerPoint slides and the webinar recording will be shared after this webinar. Now I'd like to introduce Frank Whelan, Chief Financial Officer of Health Center Partners of Southern California, who will share Health Center Partners' journey in conducting this readiness assessment.
Thank you, Marie. Good afternoon, everyone. As Marie said, my name is Frank Whelan. I'm the Chief Financial Officer for Health Center Partners of Southern California and our family of companies. And today I'm going to talk a little bit about our experience with preparing for value-based payments and doing a readiness assessment in preparation for that process. First, a little bit about our organization. Health Center Partners is a family of companies with the parent being HCP, Health Center Partners, and we have 3 subsidiary organizations underneath that. Connect, which is a group purchasing organization nationwide, Health Quality Partners, which provides grant-funded programs and quality improvement resources for our members, and Integrated Health Partners, clinically integrated network of a subset of our members. Our mission is to be the thought leader and an influencer of change in primary care, informing and inspiring our members and partners, helping to enrich the patient experience and improve the human condition. A little bit more about what Health Center Partners is and does. We are a regional primary care association of 17 primary care organizations, federally qualified health centers and community health centers. Consortium like Health Center Partners are unique to California. We have an active primary care association, CPCA, based in Sacramento, but because our state is so large, we have what is known as regional associations of California, like mini PCAs, to implement on the ground. Our consortium is made up, excuse me, as I said, of 17 primary care organizations. We provide policy and advocacy on a regional, state, and federal level for our local members, as well as providing technical training and assistance. Health Center Partners members have corporate headquarters in a 3-county area, which I'll show on the next slide. We have peer groups that meet monthly, a physician council, dental directors, operations, billing managers, CFO council, things like that. Here is the 3-county region where our members are headquartered. As you can see, San Diego, Riverside, and Imperial counties have a total population of just under 6 million, which is more expansive than I think is widely known. We reach all the way from the Pacific Ocean to the desert, from San Bernardino County to the south to the border with Mexico. Our total population represents slightly more than 15% of the total population of California and includes California's 2nd largest city of San Diego. Our 17 members serve collectively over 800,000 patients in over 3.2 million patient visits at 135 sites of care throughout 5 counties in Southern California. In addition to federally qualified health centers, we also include the Planned Parenthood of the Pacific Southwest, which is the 2nd largest Planned Parenthood in the nation, and 4 Indian health centers, both urban and sovereign. 7 of the 25 largest federally qualified health centers in California are represented by Health Center Partners. Another fun fact, over 1 in 5 San Diegans gets their healthcare coverage through our membership. Here's a little bit about the patients that are served by our members. I won't go into great detail here, but no surprise, as a border state and border counties, majority of the population is Hispanic, serve about 2/3 female, and over 3/4 of the patients that we serve are below 200% of the federal poverty level, and over half are below 100% of the federal poverty level. Here's a little bit more about the payer mix from 2017. You can see the big majority is Medicaid patients over 600,000, and then another good chunk of uninsured, and smaller numbers for Medicare, private insurance, and the exchange covered California. Now I'll talk a little bit about Integrated Health Partners, the clinically integrated network that did some work around preparing for value-based payments. So we're responsible for the financial and clinical components of what our members do. The CIN brings together 9 of our community health center member centers, was launched in March of 2016, but a lot of work happened before we could put that bullet on a slide. The work started in earnest in January of 2013 with the formation of a strategic partnership work group. The initial startup fees to investigate and decide on the structure were split among those in the work group, and there was a nominal cost to each participant of $100,000, and we did have some grant funding to help with the initial consulting fees. All of our health center C-suite staff of health center partners were invited to participate, and if they didn't, they would have to defer to the decisions of the active group. There were subcommittees created to set up the governance, an organizational design and governance subcommittee, a management services organization, RFP group, and pro forma for actuary analysis of the enterprise. We had 1-year minimum clinical thresholds in place, and all the participating members had to agree to certain thresholds. All the members were evaluated and tiered out based on a standard set of criteria. There was a matrix of several factors, and an organization's readiness from governance to finance, clinical, leadership. In some cases, health centers were tiered out until they could prove that they met the minimum thresholds. With the benefit of $2 million in seed money that was raised by the consortium, we incorporated in 2015, seated the boards and committees, and hired staff by the end of the year to negotiate the contracts. Our first contract went live in May of 2016 with the Molina Health Plan. So why did the members decide to do this? The idea was to achieve better health outcomes and financial stability. Unlike most other areas in the country, San Diego County doesn't fund or operate a public hospital or health infrastructure. The membership of health center partners make up the safety net, and that's been the case for over 40 years. The integrated network is the next step for the safety net and the growth goals of our members, which is not in brick and mortar or locations, but rather in tighter clinical and financial integration. Also, because of payment reform initiatives attempted in California, our members wanted their own experience and data to inform Sacramento on what it would take based on their real-time experience. Here's a little bit deeper look at the membership profile of IHP. At the time, there were, last year when we called this data together, 10 health center members, collectively over 600,000 different active patients, and 141,000 of those were IHP enrolled members in IHP contracts. Happy to say, as of the beginning of this year, we've added to that number, continues to grow, and now we're over 220,000 members in IHP. At the time of this data in February of last year, the majority was in the Molina, our first contract. We also had IEHP and Care First as active contracts. You can see in the lower right pie chart, the line of business is overwhelmingly Medi-Cal, 94% of our membership, and then smaller amounts for the covered California exchange plans, Medicare Advantage, and the dual eligibles. And here's a look at the value proposition of IHP, how the system works today. It's one network that can demonstrate value and effectively manage populations for primary care. We're contracted through the clinically integrated network for primary care capitation plus, per member per month with a pay for performance incentive on top. We call it primary cap plus because it's a PMPM for all the health centers do within their four walls, which is more than a standard primary care physician practice. The clinically integrated network is wholly owned by health center partners, and IHP holds the power of attorney to contract on behalf of its members. So here are the core elements of the CIN, the clinically integrated network. I won't read through each bucket, but again, we're responsible for both the financial and clinical elements. This is what happens today, and it's the infrastructure that will help with the clinical transformation as we move to value-based payments. We operate 5 committees: clinical, operations, financial, IT, and quality improvement, and we have minimum clinical thresholds for participation. Those thresholds ratchet up every year. We're now on our 4th year of clinical requirements, where performance is evaluated across HEDIS focus measures that are determined by the clinical committee. This year we had 13 focus measures, and that determines at year end our pay for performance value-based distribution. So in this way, we have elevated the HEDIS scores from the minimum performance level to above the median in just a few years. And here is the model that we look at as far as where we are in the care continuum as we move towards value-based payments. We had a proof of concept. It's worked out pretty well. And right now we're in preparation for value-based payments on our way to being responsible for the total cost of care. So why do we want to prepare for value-based payments? Well, we're considering the transition for a number of reasons. Access to a robust specialty care network or hiring our own regionally dispersed specialists placed by demand and availability. The data and counter data. So in a risk-based model, we become the payer. Instead of being paid just for primary care, we would be responsible for the larger professional services, specialty care, and so forth. And if we can figure out a more efficient use of those resources, we can then reinvest that into our services. That also gives us data by being the payer. Clinical efficiency, we want to reduce avoidable, unproductive, and duplicative services. So being ready for value-based payments puts us in a good position to be able to do that. And then there's the ability to create consolidated quality reports, utilization review, gaps in care, things of that nature, which will help us succeed. And ultimately, as I mentioned earlier, payment reform is coming whether we prepare or not. I'll talk a little bit more about this later on, but as Premier puts it, the cruise ship is leaving the dock, whether we like it or not. So we'd rather be on the ship than in the dinghy afterwards trying to catch up. Or another way I've heard it put is we'd rather be figuring out what's on the menu than to be on the menu ourselves. But ultimately it has to do with being proactive rather than reactive and letting it happen to us. So this is one model, one idea of what that looks like in a value-based payment situation where we would be responsible for the left bucket there, the green bucket. A funding source would pay the plan, and then we would receive a payment that would cover all the professional services, primary care as we do now, as well as specialty care, ancillary care, supplies, etc. If there's a deficit, that would be IHP's responsibility. That's the nature of value payments and risk. We would pay for those services. And then the right-hand side, the facility bucket, would still be the responsibility of the health plan. And we would still be able to drive some savings there, and there's potentially a shared risk pool if there's a surplus left over at the end of that. So this means that we need to look at care model redesign, what we're doing now, what we need to change to be successful in the future, with the next step being value-based payments. That transition will mean that our members need to have core managed care principles in practice. Preventative care, being a medical home is key. Making sure there's sufficient access and availability, being able to anchor patients, providing after hours availability, making sure providers can be reached in 30 minutes, avoiding unnecessary emergency department visits, being able to offer same-day appointments, and making sure we have access for appointments within 7 days of hospitalization. Patient education on the appropriate use of the ER, trying to avoid some of that utilization, direct radiology to freestanding facilities, making sure that our providers in our health centers are practicing up to the full extent of their licenses, and being able to maximize performance for our health plan pay-for-performance measures. Our HEDIS targets, ultimately our goal is to reach the 90th percentile. We've done that on some of the measures. We still have a ways to go on some others. We want to make sure our encounter data is timely and accurate, and that we're doing a good job with our HCC coding. And that'll all help to optimize for those incentive payments that we can then reinvest into the care that we deliver. Ultimately, it's about moving from providing primary care to managing the care of our patients. So to help us prepare, we engage Premier Healthcare Consulting as subject matter experts to complete a managed Medi-Cal value-based payment readiness assessment for our members. We had a strong relationship with Premier through our GPO Connect, and we talked to a few different vendors, but ultimately selected Premier as having really impressive backgrounds and knowledge on this subject. Our members each received a unique assessment based on their market, their patient base, their payer activities that established a readiness assessment for value-based payments. And since we have a network strategy, an overall strategy at the top, IHP also received an overall executive summary and an assessment for the network. So here's a look at how Premier frames this transition. There's, in the recent past, most arrangements were without risk, and the shared savings was compared to past costs. And we were really just talking about providers and third-party entities. Whereas now we've moved into a little bit of two-sided risk. The benchmarks are looking at the budgets and episodes or the total populations, and now we're getting other risk-bearing entities involved, such as IHP. The future, they talk about Medicare Advantage as a prime example of this, but the value-based payments moving forward, it's going to ultimately move to full risk capitation, the benchmarks based on a global budget, with health plans being the participants. The findings broke down along 5 different dimensions that we'll talk about, and I'll kind of go through each one individually. The first is the organizational understanding and culture, just very basic of what was the knowledge base, what's the culture, what are the similarities, what's common across the different organizations we work with, and what's not, where are there gaps and differences. So I really broke it into 2 sections: the opportunities where there's a room for improvement and really a need for improvement, and then the existing strengths. What foundation do we have there? What do we have to work with? So with respect to the organizational understanding, they found that the understanding of what value-based payment arrangements were, or the reason for IHP to move to value-based payments, wasn't very strong once you move down below the C-suite level. The CEOs got it, the C-suites understood, but that message wasn't really percolating down and reaching the mid-management or the line-level staff. There was a lack of standardized care coordination across the different health centers, with a minimal understanding of the line staff's role and what the process was. So each health center was doing it differently, and some were doing it better than others, but it wasn't standardized in any meaningful way. There were communications issues. The communication of what the IHP strategies were, what our efforts were, wasn't filtrating down to the staff at all levels, kind of a recurring theme there. And there was an inconsistent culture of change depending on the health center. So some were suited up, ready to go, ready to take the leap into this next phase, and some were a lot more hesitant for understandable reasons, but they weren't all on the same page, and the cultures were different. Where there were strengths was that the culture of change was positive around the need for change at the executive level, provided that the strategies are in place to support the change naturally. So the senior leadership, the CEOs and so forth, really were supportive of these efforts, and they understood the need and the reason behind doing this preparation work. They also found the clinical providers were ready to engage. They were really willing and eager to engage so that they could positively impact patient care, which ultimately is what it's all about at the end of the day. So it was a good sign that the clinicians were on board and really wanted to improve the patient care. The community health centers, they already have a strong patient-centered model. They have been doing PCMH and becoming health homes. So they've been providing this care to their populations. So they are ready and already doing that to a large extent. Another area that was Premier looked at was excuse me, the market and the network. So throughout IHP, there was an inconsistent understanding of a high-value network, what it is, what that means, and why we need it. There weren't really meaningful, active, two-way relationships with the hospitals, long-term care facilities, post-acute providers in terms of data sharing, talking about utilization or cost avoidance. Definitely not alignment on those areas with those potential partners. And while IHP had shown value with networking, best practice sharing, and collaboration, which is kind of, I think, a history and the legacy of the work that the health centers have been doing together under health center partners, those aspects were strong, but not so much as far as network management, managed care contracting, or care management. There still wasn't broad alignment on those particular points. The strengths were that there was an existing IHP specialty care network that, and we do have a continued focus on developing that and building that out. We have the bones of that network of specialists that we can refer to that are high-value specialists that, you know, have the costs have been beneficial to IHP, and they've been good partners to work with. So that does exist. The leadership and the staff understand the importance of the network partners, including the specialty care providers. So throughout the organizations, the staff really understand why that's important. That's where there's the opportunity in value-based payment to be responsible for the specialty care and manage the costs and manage the care in a way that we can positively impact our patients. And then the individual health centers, some of them have employed or subcontracted specialty care providers for their high-need specialty care. So they already have brought that capacity in-house in one form or another. So they're well positioned to be able to manage those specialty type cases. Then they looked at a big component of this is the financial readiness, where there were opportunities were that there really wasn't much tolerance for downside risk because of the financial implications, or there was just a lack of understanding of the strategy and the alignment with the overall IHP network strategy and the local individual health center strategy. So the lack of alignment there was a challenge because it wasn't clear, you know, where this risk was going to live or how exactly this was supposed to work financially. To a certain extent, they found that inconsistent reporting of the financial performance that was tied to the quality and outcome performance. So each health center had their own way of reporting it. There are network level reports, but they weren't well understood or fully utilized. There was no current reporting or trending of the total cost of care for patient activity that included activities outside of the FQs. And really, this comes up a little bit later, but that's because we're not receiving the data. You know, we're not paying the specialty claims. So if it's not happening in the individual health centers that are part of IHP, then we don't really have visibility into the cost. So that makes that hard to prepare for being responsible for that cost. And then there's a varying impact across the different health centers, from some changes in California to the 340B pharmacy regulations that are impacting all of the health centers, but some more than others that will see a negative financial impact from that, that makes them, particularly those that are harder hit, are more reluctant to take on risk, and they're already feeling like they're in a little bit of a precarious situation. The strengths in this area were a very strong engagement of the financial leadership, the CFOs and their finance staffs, and as far as the process improvements needed and the strategies that are needed to be successful. The contracts we do have, upside only Medi-Cal managed care contracts. So there is some familiarity with these types of contracts being paid for the population health, not taking downside risk, but at least there's some experience with upside only contracts. And some of the health centers have already aligned their physician compensation with performance. So not all of them, and this will come up later, but this is an area where we need to get alignment and harmonize the approach. But historically, there's been an optimization for being paid for volume and number of visits for individual provider and health centers as a whole. Whereas if we are moving to value-based care, it's not necessarily going to be the same model. We need to make sure that the physicians are practicing up to the full extent of their license. And the physician compensation, really, it's important that it be aligned with that. And they looked at the electronic medical records and the data tools. One big challenge with the 9 different health centers is there are 6 different EMR systems across the FQs. So having different EMRs does pose some challenges necessarily. There's inconsistent access or use of the health information exchanges, the HIEs, and particularly in San Diego, I know that's been a challenge for some of our members. A little bit more luck, better experience in Riverside, but it's still generally a challenge. At the individual health centers, there are different population health tools that are being used for care management or the quality reporting. So similar to the different EMR systems, different pop health tools that aren't necessarily compatible. In the same vein, there are multiple financial analytics tools that are in use, and there are inconsistent reporting processes and utilization in process improvement efforts. So again, the individual health centers are kind of doing their own thing. And IHP is in the midst of implementing a new population health tool, Arcadia, and that will be able to ingest data from all of the different EMR systems, the HIEs, claims data, payer data to the extent that we can get it. So that will be a really useful tool that will be able to aggregate that data, report on it, and give us some actionable insights. So as I said, that's in the middle of being implemented. At the moment, there's an inconsistent understanding of how that's going to be utilized. So it's not well understood, and it's understood better in some places than others. The strengths to build on are that we are implementing this Arcadia population health tool. As I said, it will be able to aggregate all of this data and report at the network level, which will be a very big advantage for us to have once that's up and running and live. There are dashboards and analytics that have been created by the FQHCs so they can manage their internal quality improvement processes. So they've been doing this for a while. They have their own processes set up. So the challenge, the opportunity will be to standardize that and make sure that everybody is on the same page and has the same priorities. And several of the health centers are in the process of training their staff to be Lean and Six Sigma certified. So that will certainly help as we go through the clinical transformation process. And then finally, in terms of population health management and care management, they found that there's really no consistent care management techniques for risk stratification, patient navigation, care coordination, or closing gaps for the Medi-Cal managed care providers. They're really, individual health centers are doing their own things in the way that they've really always been doing them. The idea, the very concept of population health means different things to different people, and there's big differences in understanding across the different health centers, and it doesn't really include, at the moment, doesn't include care management outside of the FQHC clinics. The approach to risk stratification and care management aren't linked necessarily to maximize the return under our contracts. It's kind of a historical way of doing it, or an internal understanding as to how to do it, but it hasn't necessarily been linked to maximizing the return on our contracts and performing at the highest levels under those agreements. And there's a big disparity of staffing investments from the large health center members to the smaller ones for these operations. So I think this kind of stands to reason, but it's a challenge that we have to face, where the larger health centers have more resources generally and larger staffs to devote to quality improvement, population health, IT types of initiatives, whereas some of our smaller members really struggle in this area because they don't have those same resources. Their staffs are kind of stretched thin sometimes, and they can't devote as much time to some of these initiatives. The strengths that they found were that there is a team-based approach for patient care with the integrated primary care and behavioral health teams using the PCMH model. So they've been doing that for a while, and I've gotten really good at it. There's a structure of engagement, provider engagement, in the majority of the members. So that's really critical. If there's not provider engagement, then it makes the whole enterprise really dubious and a lot more challenging to get off the ground. And there is a quality improvement process at the health centers that monitor the HEDIS measures. As I mentioned before, the paper performance incentives are largely tied to HEDIS measures for Medi-Cal, so that is being monitored pretty closely. So those were the findings of Premier as they went in. So they found, some good foundational elements, some good strengths that were in place, and of course a lot of opportunities, which we knew would be the case. That's why we had Premier come in and do the work. So the question becomes, now what? What do we make of all this? So they did have a number of recommendations. As I said, there were individual health center level recommendations, and then I'm going to talk at a very high level about what the IHP network level recommendations were that Premier shared with us. The first was what they call a CIN refresh, a clinically integrated network refresh, where we create a value statement of the CIN. What is the value statement? What is the scope of the network? What is meant to be done at the network level, and what is going to be delegated or relegated to the individual health centers? And that's something that they recommended that we really create at the network level, at the IHP level. And then the health centers are going to be responsible for distributing that to all levels of management and staff, and making sure that it really gets understood and appreciated, because as we saw earlier, some of the findings were that message wasn't necessarily disseminating down throughout the staff, so it wasn't clear, what the strategy for IHP really was. They suggested that we have some sort of initiative towards vision alignment and strategies. We create a value-based payment strategy as a group, and we create a contracting strategy for managed care contracting for the top payers that we are going to go after. We've had some success in that area. 2 of the 6 Medi-Cal plans, 2 of the top 6 in San Diego, are now under contract as of January 1st. But what's the strategy? We've pursued opportunities as they've come up, but what's our overall managed care contracting strategy, developed again at the IHP level? And similarly, in terms of aligning vision and strategies, what's the population health and the care management strategy for the network? And that's where Premier is suggesting that there's work to be done both at the IHP level as well as at the health center level. They suggest, in terms of the CIN refresh, some governance updates. We have a management services organization that provides a lot of services, but Premier identified some significant areas of potential process improvement. So there's a body of work there and around the MSO process improvement. The population health process improvement. So there were a lot of issues alluded to in the earlier slides around the population health. So we need to get a handle on process improvement in that regard. And that's a shared responsibility of the network as well as the individual health centers. And then getting a handle on contract performance, making sure that we're performing to the best of our abilities, that we're tracking the right measures, that we're aligned with our contracts, so that if there's an opportunity for incentive payments or growing membership or what have you, that we're taking full advantage of that and getting as much information from those partners as we can. They recommended a lot of effort devoted to a communication strategy. That was kind of, again, a recurring theme where we need a general communication and action planning for process improvement done at the IHP level, but then again, important that the health center partners disseminate that information to all levels of their staff. Recommendations around population health and care management. We need to create a population health strategy at the IHP level, establish the network population health strategy that is aligned with our managed care payer quality and process expectations. And then once that's created, outline the pop health strategy components and educate the leadership and all of the staff on the strategy and alignment. So that goes hand in hand with the communication plan, but getting that information, getting the strategy into the hands of the staff at all levels of the health centers. Establish a care management strategy. So similarly, use IHP work group that consists of clinical and non-clinical personnel to establish a strategy for care management that aligns with the contracting, again, what the patient needs are, what the abilities are of the individual health centers. We have to be able to meet them where they are, social determinants of health, all of those elements. And then finally, in this area, developing a staffing model to support these strategies. At the moment, the IHP staff at the network level is very lean. We really, there's a lot of focus on the individual health centers doing a lot of this work, and we are coordinators and facilitators. But the suggestion is we really need to create more resources within IHP that can support this population health and care management, these new strategies, and ensure that they're communicated throughout the network. And then at the health center level, develop that structure with their staff to partner and align their efforts to make sure that we're all in alignment and can ensure success for the pop health and the care management elements. For the managed care alternative payment model, the suggestion is we establish an IHP strategy. We need an IHP managed care APM strategy for the top 80% of the Medi-Cal and also the Medicare Advantage market, and really figure out how we're going to relate with those top payers in our markets. And then the next layer kind of beneath that is developing a process for the managed care contract performance. So we have an existing governance structure. We can use that to develop a managed care contract performance process for data reporting, analytics, and making recommendations to the board based on our performance with each of the payers. And then at the health center level, establish, devote the staffing and the leadership expectations around what are the expectations around communication, and what are we going to do on contract performance, and what happens, what's the accountability, what happens if there isn't performance, how do we improve? And then communicate those contract expectations. So, similar format to the previous, but establish the strategy, develop it, and figure out who's doing what where, and then make sure that gets communicated out. So same way with this APM, creating the tools at the staff level so that the payers, for the contracts with the payers, and making sure that there's a complete understanding of the expectations for the payers and the providers. And then providing monthly updates and educating on a consistent basis for the performance, and if there are changes to contracts, making sure that's covered to all levels of the staff, so it just doesn't stop at the leadership level. And then developing a workflow for the managed care process, and outlines of contracts to complete on-site staff and provider education programs, and have regular expectations. They're suggesting quarterly expectations as to what happens with each of those. With respect to developing a high-value network, I spoke a little bit about this earlier, but we really just need to build out the high-value network, align with the population health and managed care quality strategies, figuring out who are going to be the best partners for our network, and then going out there and ensuring that there's a full complement of all the specialties that we need, geriatrics, long-term care, post-acute providers, to make sure that it's really complete and robust, and that we can rely on our own network, because then we have more control over outcomes, cost, utilization, things like that. And then population health network expansion, where this is establishing relationships with the facilities that are influencing the total cost of care. So we can establish this network of non-clinics and an ambulatory network, and then begin the conversations with the managed care payers on sharing data so that we can really get at the total cost of care. What is the cost of the tongue depressor, down to the really minute details that'll help us see where the trends are and how we can manage that better. Because I think there's still a lot of opportunity, and that's the sort of thing that's going to be really critical as we take responsibility for those sorts of costs. Around IT and data analytics, the recommendations were to outline the Arcadia population health tool strategy and what its intent is, to clearly establish this strategy and create an intent document that utilizes clinical and non-clinical input from the FQHCs, something that the IHP would undertake, and then finish implementing Arcadia. As I mentioned, we're in the process of doing that, but using our strategy and intent document that we establish, then we can complete the implementation of Arcadia on a schedule that is logical and makes sense with the input of the member health centers and with their cooperation. And excuse me, establish a reporting and analytics process to make sure the reporting is clear, the expectations for the tool and for the teams that are using the tool are clear. Is this going to be used just at the network level, or are we just aggregating data? What's the expectation for the individual health centers? Are they going to be using this tool, and what exactly are they supposed to do with it? So once we have our strategy in alignment, I think that will be a lot easier to do. We need to establish a governing structure for the analytics and process improvement and action planning that are aligned with the earlier strategies around pop health and care management, because that's an ongoing process that keeps evolving. So we need to make sure that the governing structure makes sense. And then again, communicate and create a monthly reporting package and a dashboard that aligns with these top strategies so that everybody is on the same page. And finally, around coding and compensation, I think these are really big elements, kind of simply put, but critically fundamental. Provider coding education, that we need to develop a provider education program that has an emphasis on the contract, our managed care contract improvement areas, social determinants of health, and where we know there are missed opportunities. And that's in partnership with the health centers. It's not just something that IHP can push down. We need to develop this in conjunction with our member health centers. And then help with the provider compensation structure that was discussed earlier, develop an IHP level clinician compensation best practice that's a standard, and it becomes the standard for all of the clinical providers that all of our health center members can live with, and that is perfectly aligned with the strategies that we've outlined in the earlier steps that we talked about. Because if the physician compensation isn't aligned, then it'll be really difficult to get any of these initiatives off the ground. And then implement it. So really implementing that compensation structure that's in alignment really needs to be done at the health center level, because at the end of the day, the clinicians are employed by the health center, so there needs to be a shared responsibility for we develop it and then implementing that structure. So there's a lot of different buckets, a lot of high-level information. The way it breaks down, the way that Premier framed it is really 3 phases, and in different chunks of time, 3 and 4 month increments, a little less than a year in total. But the first phase is about 90 days, and that's mainly around the CIN refresh, which again, that just entails ensuring that there's a true understanding of what a clinically integrated network is, how the clinically integrated network works with the member health centers and their staffs at all the appropriate levels. It's about creating an overarching pop health and care management strategy and a staffing model that supports them, developing a managed care strategy and a contract performance process, and communicating contract expectations to the member staff at all the appropriate levels, building a high-value network that aligns with contracting and risk stratification strategy, being selective, expanding the network to the full continuum of care in a selective way, partnering with community-based organizations with best practices and leveraging their strengths, developing the Arcadia strategy, including the change management and communication that's needed to finish implementation, and the reporting and analytics processes. And then coding being key, developing provider compensation and incentive structures with shared core principles across the membership, investigating the best practices, investigating how coding is linked to best practices, ensuring quality performance across the membership. So those are the high priority kind of shorter term initiatives. Then we get into the other phases of fleshing out the top health care management strategy, the managed care strategy in the 4 months of the phase 2, and then finally phase 3, 4 months of fleshing out that high value network and finishing the IT and data analytics. So I think it's a pretty aggressive timeline, but our members are motivated and really want to make sure that we are prepared, and who knows what's coming in terms of what will be imposed upon us, but we're going to do our best to make sure that we're ready. And we plan to move forward with Premier. They can help us with a lot of this work and meet our members where they are. The smaller ones, I think, will need a little more hands-on help, and the larger ones will kind of help them in a little different way. So finally, what's the expected return on investment? Well, it's all these different dynamics, aspects to look across, but looking at the mission versus the margin. If we can improve our care and expand our mission while increasing margin, that's, I think, something that we can do with our risk arrangements. So that's where we'll see some return. In terms of innovation, we'll encourage innovation in clinical and business practices and hope for continuous growth and continuous improvements. Getting back to what's our mission? What's fundamentally, why do we exist? Why are we here? We want to serve the vulnerable populations, and they deserve top value care. So we're dedicated to quality improvement for their sakes. Impacting the total cost of care will allow service expansions and reinvestment in the health centers so that we can provide more services, provide the services we do to more individuals. Maximizing the clinically integrated network, we can utilize it to grow our market with a focus on quality care, which is really what it's all about. Engaging with the community, we can engage with community providers and expand what we offer to our patients again, and aligning the teams. So the process improvement, focus on quality across the teams will build the teamwork and the team competencies. So you've probably seen a pyramid like this, but really at the bottom, the foundation of the pyramid where people change is the change and the learning and what the leadership behavior is. And then the work starts to change with the management systems and the processes. And then at the top of the pyramid is where we realize value. So I would say this was a really great process that we went through. We saw a lot that we kind of knew a little bit about, but learned, helped to have it framed by the outside party, Premier. If you're considering this kind of work, highly recommend it. But I think you have to be ready to act on the results. There's no reason to go through it. It's a lot of work, a lot of time, a lot of expense. But so you have to be prepared to really act on it and do something with the knowledge. And be able to face the reality. We have 9 different members, and some are more prepared than others, so they all have to be able to come together and hold each other accountable. And that's not always the easiest for particularly individuals that have worked together, worked with each other for quite a long time. So our members have seen the importance of doing that, and I think they're ready to start taking the next steps. So that concludes what I had prepared for my presentation.
Great. Thank you so much, Frank. It's been really wonderful to hear the efforts of Health Center Partners and your work with Premier on this readiness assessment of your members. I now invite those who are on the webinar, if you have any questions from what you heard in the last hour, please use the Q&A function, which is located in the bottom panel of your screen. You can also use the chat box if you're more familiar with that. So please, we are now open for questions if you have them for those on the line. All right. It doesn't look like we have any questions, and we're getting close to the end of the hour. I am going to launch a poll for those who are on the call. This is just to help us better understand if the content we're providing supports your quality improvement efforts. The poll is anonymous, so please make sure to let us know your thoughts about the content today. Again, this webinar was recorded and will be posted on our website. Please feel free to share this resource widely with your networks once it becomes available. For other technical assistance resources, please go to CIN's website at www.chcf.org/CIN. And it looks like actually, Frank, we did get one question, so I'm going to offer it because we have a little bit of time. So what does your organization do to train and support process improvement and other methods with your FQHCs, with your member organizations?
Sure. So in terms of what we do to support, it kind of depends on what the request is, but a lot of times we'll bring in outside subject matter experts and have them work with whatever the group is. For example, with the coding, there's a lot of focus on improved coding. So we're hosting an event here in a few weeks on HCC coding that's targeted at the billing managers of the different health centers. So that's always, we do that periodically, and it's pretty well received, and it's driven a somewhat of an increase in our coding performance and our HCC scores. So we'll do things like that. If there's internal subject matter expertise, we offer that as well. The larger parent organization is really focused on, in addition to the programs that we run, policy advocacy and communication. So we do have internal policy and external affairs people that we get in front of the members that help them approach certain things. Like we had the funding cliff for federally qualified health centers about 2 years ago now. So there were a lot of resources devoted there. So it just kind of depends on what the need is.
Great. Thanks, Frank. All right, so we'll close the webinar now. Thank you to those who attended. Thank you so much, Frank, for sharing this great resource with those on the call and the CIN network as a whole. Have a great day.
Thank you. Thanks for hosting. Thanks, everyone.